Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Surgery has never been more complicated. The variety of surgical approaches and the complexity of treatment continues to grow exponentially. And yet, in most institutions, surgical training has not really fundamentally changed. Dr. Adnan Alseidi, our guest for this episode, is trying to change that. Dr. Adnan Alseidi is a liver and pancreas surgeon at UCSF and is the Associate Dean of Assessment, Improvement, and Accreditation. He has an amazing background and so many different research interests, including interest in AI and computer vision. He recently gave the Langer Lecture at the Canadian Surgical Forum in Montreal this year about surgical education and the path from novice to master. This episode was really a moment for us to ask all of our burning questions about surgical education. What are the phases of mastery? Should we really be aiming for mastery as opposed to competence? And how do we create trust between attendings and trainees? We'd love to hear your thoughts and comments, so email us at podcast.cjs@gmail.com. You're a man who wears many, many hats. You just mentioned that you moved into a new role where your boss is not a surgeon. Can you talk a little bit about what your clinical and your academic profile and practice looks like right now?
Yeah, my job now is obviously very different than my job even a year ago, and certainly very different than my job 5 years ago. In the last 6 years, there's been a huge shift in what I do and how much I do clinically and how much I do educationally and research-wise. And so, as I said earlier on this year, I took on a associate dean position in UCSF, and it's really an exciting role for me because what it is basically takes the three pillars of assessment. The second pillar is evaluation and QCI, and the third is accreditation, and actually lumps them under one title. And the beautiful thing about that is that the data team and the AI team are all encompassed. And so you basically are able to create situations where you have data flow to have precision education for the learner, and that's assessment, precision education for the course or for the program, and that's evaluation, and then precision education for the hospital or the school, and that's accreditation. And so it's all just flows from one to another to the third tier. And so it's been very exciting. The consequence of that, of course, is that I have to stick to my job description, so I operate less. And so currently my job has shifted so that I'm doing a lot more education and research, but obviously still in the OR. I'm doing a lot of coaching and helping out a lot of the junior faculty and working a lot in our safety net hospital, which is the general hospital, which is always a special place in my heart to be there too. So it's certainly an opportunity for growth. I'm pretty excited about this position. And Dr. Sosa, who's my surgical boss, has been incredibly supportive throughout the whole process, and that's been amazing.
So you gave this incredible talk at CSF about how we learn, how we train, how we evaluate people. And I want to pick up right away on the three phases that you talked about there. So can you just go through what you just said about those sort of three phases of a learning program or creating an educational program?
The three phases are the importance of basically separating how we actually use data, but then making sure that data feeds upwards in different levels. So we want to make sure that we have formative assessment, meaning assessment for learning and assessment as learning for the learners, because that's how learners grow. We know that there is no learning without assessment, without feedback. And so data needs to be accessible, needs to be formative, needs to be low stakes so that the learner can learn. That same data can move up to actually, in aggregate, give us feedback on, is the program working? Are we creating competent individuals? Are they becoming competent in spite of us or because of us? Sounds kind of a silly question, but it is actually a real question to ask. Because we are very, very, very blessed and lucky in Canada and the US and in the world that we have the best of the best going to medicine. And often they just become good doctors because they're just good people and they're just hardworking and not because of the program. And how do we fess that out? And that's where evaluation comes out. All that data then goes up to the hospital and goes up to the school to say, are we doing a good job? Are we, where's our accreditation? Unfortunately, a lot of times people look at it the opposite way, where they say, let's focus on accreditation. Let's invest on accreditation. And they spend years. I mean, there's an op-ed published by NYU. I think it was like $3 to $4 million spent on accreditation. It's like, why are we doing that? If you spend it on the ground level and that data flows to accreditation, accreditation becomes a no-brainer. It's an afterthought. It happens because you have all that data. You've accomplished it. So, but that's different than looking at the learner and the learner's progression through their phases of training. And this, what you mentioned, my talk at CSF, and thanks for mentioning that. The idea of like, how does a learner grow to competence? And then how do they go from competence to proficiency and to expertise? And this goes back to a model, the Dreyfus model, which is not a new model, but the idea is if we use that as a scaffolding, we can basically then deconstruct like, how does learning happen so that a learner goes from novice to competent? And then that's one phase to study. And then there's a lot of questions about what happens when a learner is thought to be competent, and then now they see the whole picture and they're sent to practice independently, which is basically they grow through proficiency and then they hopefully achieve expertise. And that's a different story altogether, and how we can help those individuals.
What's the Dreyfus model? What is that?
So that's looking at basically at individuals through their phases of basically how they get skill acquisition, right? So we basically look at an individual as their novice, and then advanced beginner, and then competent. And usually schools like whether you're a medical school or a residency, you have a set of criteria to say, for somebody to finish this program, they need to achieve these competency levels, like in, whether it's CAN-MEDS or ACGME or the AAMC, depends on your level. Once you're competent, you're basically at that point seeing the whole picture. You have intuition to know what's right and wrong. You're basically practicing independently. And the growth doesn't stop there. At that point, you're going to continue to proficiency. And unfortunately, like we discussed in Montreal, a lot of times what happens is we see early and mid-career individuals never really achieve expertise because of this blunted expertise, arrested development, because they're not getting feedback, which is not what used to happen in the past. But that's different than the growth within a program, which goes from novice, advanced beginner to competent.
So I just want to pick up on a few of these things. And, Chad and I have been obsessed on this podcast, as you may or may not know, with mastery, right? Like, one of the things we're both obsessed with is how do we get surgeons to be the best versions of themselves, right? Not the best, but the best versions of themselves. Can you just break down a little bit, what's the difference between being competent and being proficient? Because sometimes I think those two things are used interchangeably, and the way you're using them is not the same.
Yeah, it's a great question. I always say that we educators complicate things by using the same word to have different definitions. So unfortunately, the word proficient is actually used in defining competence, which is a bad thing, right? It just confuses people. It's not bad, it just confuses people. What I'm talking about is this. Competency means that you understand what's important and your actions are deliberate and you actually know your limits. And remember, competency is not just ability. And this kind of comes to the discussion we had about trust. But that's what we're saying. We're saying, here's a set of competency levels. Let's just keep it simple, talk about residency. Here's the set of competency levels, whether it's in the US as ACGME or an RRC or the CAN-MEDS in the Royal College in Canada, it doesn't matter. Have you achieved these? If the answer is yes, and that should be a committee-based answer, then you are considered to be competent. And at that point, you transfer to a situation where you're basically practicing independently. Proficiency is a little different. Proficiency is when you're able to actually see the whole picture and actually calibrate easily and more smoothly and also almost intuitively to what's happening in terms of changes in the outside world. Meaning a patient is obese, or a patient is on blood thinners, or a patient is, has multiple things together. You can still do that when you're competent. However, you're not doing it intuitively. You're doing it a little bit more rigidly. Proficiency is when you become a little bit more intuitive. This is also different than what we call an expert, where experts are acting mostly instinctively, but also are able to recognize patterns that are actually outside the norm. Meaning an expert can see a dissection and say, this doesn't look right. Something is a little bit off, and actually then employ an adjunct to actually decipher that. We don't see that in proficient people. We see that in experts. And this is where proficient surgeons may have, excellent results. but they will have a complication 1 out of 20 or 50 or 60, depends on what they're doing, versus an expert can avoid that by this unconscious competence that they have, which is instinctive.
That makes so much sense. One of the things you just very briefly mentioned, Ed, and I was hoping you could expand on, is the concept of or your observation of blunting sort of this traditional educational arc towards mastery or towards a successful training cycle. Can you tell us a little bit about why you use that word and what you're seeing and maybe what you're concerned about?
This comes out of a couple works, but the most seminal work is really from Erickson, where he basically looked at individuals in really complex fields, whether it's musicians or sports or surgeons, and actually saw that what happens is the progression, that arc, like you said, from proficient to expert doesn't actually happen just by time. Doesn't happen by, doing 1,000 repetitions, which is unfortunately a misunderstanding from a lot of his work. It actually happens by deliberate reflection and feedback that you get. If you look at, and again, I'm not a person that like looks at the past and say we need to do the past, because our practice today is completely different than the past. But if you look at the past and you actually see how surgery was actually simpler, and I mean this with all due respect, the stuff we operated on was more straightforward. The technology in the operating room was much, much less technology. The instrumentation in the operating room was actually transferable, meaning if you did a AAA versus a colon resection, pretty much the setup is the same, the retractor is the same, the instruments are the same. Look at what happened to those two surgeries now. One of them is endovascular, ultrasound, CT scan, cone beam CT, all in the operating room, versus the other one is robotic, completely deciphered. If you look at that, even in those simpler days, with all due respect to those days, you still had a situation where the junior and the senior surgeon would operate together all the time. Even in my day, and I'm not that old, my first year, we counted because my senior surgeon, Dr. Paul Ryan, who's since retired, operated with me over 66 times in my first year. That is an incredible wealth of knowledge to actually make sure that the junior or the mid-career actually then kind of progresses to expertise. We don't see this. Right now, we deploy these individuals. Unfortunately, we even make it harder for them because we have so much technology in the OR, so much complexity in the OR, and then we give them emergency call. So they're taking the sickest patients, and there's like absolutely no feedback. And we think, oh, M&M is feedback. M&M is not feedback. There's no reflection in it. You're just looking at a complication. You are actually assuming what happened wrong. And that's the problem with the blunting of the arc. And that way we don't see people achieving expertise. It even gets a little bit more complicated than that. And please stop me, Amir, if I'm talking too much, but it gets even more complicated than that, because even if you are one of those individuals that learns, that watches your videos, that gets feedback and actually achieve expertise, and then all of a sudden you decide, oh my God, I need to start doing this robotically, or I need to start doing this endoscopically. Now you're introducing innovation, and we have data to show that you can actually drop out of expertise. And so now you were expert, and now you drop out of expertise and you start the arc again. And now are you getting feedback or not? And that's the problem.
That's a brilliant observation. I really like that example you just gave about AAAs, because you're so right. The setup, the instrumentation, 50 years ago would have been exactly or very nearly the same, right? Maybe it's slightly different retractor,
even 10
right?
years ago.
Yeah, right. Yeah. Like it's like maybe you're a Thompson guy, or maybe you're a Bookwalter guy, but really fundamentally it's the same sort of idea setup, the same sort of set of approaches, right? In many ways was very similar. So it's true that our lives are much more complex. So one thing I have to push you a little bit on, and I've always had this little bit of a beef with even just the term competency-based medical education, right? So I get it. That progression that you just said makes total sense. But I think that's one of the tensions in residencies, right? So you have a trainee that you're going to send out into the world. And you just said, there's big differences in terms of people being able to tell that, oh, this is a different pattern of disease that I'm seeing here, right? I'm going to do XYZ operation, but now I need to recognize that this is something, there's something different here. Patient factors are different. The disease factors are different, something different in the situation. And we're going to send people out, let's say, into independent practice in Timmins, Ontario, wherever. Like, these people can't go out and be competent. They have to be masters, or at least proficient, that they can say, this is not what I'm used to seeing. I shouldn't be doing this, right? So
I just personally have this whole beef with the idea. I never wanted to be competent. I don't want my trainees to be competent. I want them to be superb. I want them to be masters. I want them to be excellent. Am I just unrealistic or?
No. What you're saying is perfectly right. It's a rigid model. Amir. When we say somebody's achieved competency, we are actually saying they've basically now beyond competence. They are now ready to practice alone. That's the whole point, which actually includes the idea of saying, remember, the idea of trust is not just ability. And right, it's also the idea of basically knowing your limitations, and so competence, achieving those competency levels actually includes what you're saying. It includes the idea that I am competent in doing a cholecystectomy, but I'm also competent enough to know that if I'm doing a cholecystectomy, if I have somebody who I think has cholecystitis and I take him to the OR and I am in the operating room and I see this and I'm like, why does this look like a mass? I'm going to stop. I'm going to not do the cholecystectomy and I'm going to refer it to an HPB surgeon. Things like that. I'm going to stop if I can't do a cholecystectomy because of a hostile cystohepatic window, and I'm going to do a subtotal. So competence does include the ability to actually alter definitions with respect to what you're seeing. It just doesn't include you doing it. It includes a judgment of you basically saying, I have to stop.
I'm glad you brought up gallbladders because I'm sure you're inundated with people doing subtotals or bailing, and then you go back to do the gallbladder like, well, I wasn't there with you originally, but I'm not sure that this was something that you necessarily needed to bail on. I guess my question is the idea of saying, oh, we're going to make people competent. Are we giving up on an opportunity to push people? And I think this partly plays into trust as well too, and what our expectations are of trainees. But by accepting this idea that we're just going to make competent people, is that somehow sending the wrong message? Should we not be asking people to become masters, or is that not realistic in our day and age where there's so much complexity?
I think you bring up a much bigger question, Amir, which is the question of like, how are we designing our world of healthcare deliverance, right? If you want a situation where people are actually practicing under a different auspice for a long, long period of time, yeah, you can design that model and you could basically say people don't finish until they're, really, really have achieved near expertise. Those models exist. Our model here is to basically say, we want you to achieve a certain level of competence and a certain level of proficiency that you actually know your limitations and know when to ask for help. And that's acceptable, right? And so it's just a matter of how you design things, right? And is there one better than the other? Well, it depends what your outcome you're looking at, right? If you're looking at outcome of actually getting out and practicing and actually getting individuals to actually own their life and actually have good medical outcomes, but at the same time have a profession, we do much better. But if you're looking at the nuances of every single medical outcome, you're right. It may be better to actually just have somebody under the auspices of another for 2 decades.
I think that's a very fair point. If you're narrowly focused on, your technical skill and ability and not on the whole person's life, then what I'm saying makes sense, or on a different model would make sense. So I think that's a very, very, very fair point. Let me ask you a few questions because I think this is so hard. This trust piece is so difficult. I'll ask you from my perspective as an early attending, right? So there's many pressures that I have, right, on myself. I have pressures, get cases done quickly. I have pressures to make sure the patients have great outcomes. There are nurses there who are like, sometimes they're like coming into your ward, like, when are you going to be done? There's anesthetists who are also somewhat in the game, sometimes not in the game. And then you have a resident who really wants to be involved in the case. And what I've observed is that if you push someone, they generally speaking can rise to the level that you want them to rise. Like, people are much more capable often than you'd initially think. Like, if you challenge someone, like a medical student, hey, can you put this port in? 99% of them can do it. And the same with residents. If you ask them to do some sort of complex skill, many of them eventually can get it, but you have to develop the patience in yourself to be able to do it. What advice do you have for the faculty side to be able to show trust in their trainees in the midst of all these pressures?
So it's a great question, and it's a very, very, very importantly practical, pragmatic question, which I love. And thanks for asking that, Amir. The way I will answer this is 2 ways. I want to point out that there's a solution for that faculty, but the best solution actually involves zooming out to the program first and then looking at the faculty. So let me explain that. First of all, There is such a thing as programmatic responsibility. Meaning, if a student or a resident comes into your operating room and you're giving them a port or you're giving them a stapler and they look at it and they say, so how does this work? That is a programmatic failure. Okay. If they come into the operating room to do a laparoscopic case with you and they're turning their hand like this to turn the instrument instead of like really turning the instrument, or let alone going to the robot and they have no idea how to use a robot, that is a programmatic failure. That is setting you up as a faculty to have lack of trust with that individual. So the way I think about it is that there are basically five things a program is responsible for. And those are setting up the faculty and the learner to actually have ability to have trust. Now, let's say you have a student, a learner that comes in and the program has done their job and they're ready for entrustment, right? Now what? Now, the way to think about it is that you have to have a communication. And the best communication about this is done earlier on. And I love a George Bernard Shaw quote that really describes this tremendously. And that is, one of the most common quotes, which is like the problem with communication is the illusion that it's already occurred. We all think we're communicating. We never communicate. And it's a simple question of like, what do you want to learn today? What do you want to be entrusted in today? And it's literally, I use that with those words, right? And they know I don't want them to tell me the whole case. I want them to tell me a module in the case that we're going to focus on, that they feel comfortable, that is exactly like you're saying, Amir, in their stretch zone. If they tell me they want to open up the abdomen, and I know they're capable of that, then I'm like, but you know how to do that. What else do you want to do? I push them to their discomfort zone. Why? Because I want them to embrace discomfort, because that's where learning happens, right? But I'm able to do that because I have that relationship with them and I can push them, and they know that I will rescue them if they make a mistake. They know that there's no embarrassment in this whole process because I already pushed them to that discomfort zone, right? So how do I answer your question about entrustment between the learner and the faculty? First, you have to push your program to get individuals ready so that they're coming in entrustment. Then when they come in entrustment, choose a module that they are comfortable, but not super comfortable in. In other words, a little bit beyond their super comfort zone, to basically say, this is the learning aspect. It can't be the whole case. And that's where learning happens. Does that answer your question?
Yeah, that's fantastic. The only thing that I would say, and I would ask you, is that, so when you talk about having a program preparing residents to be, entrusted, so someone's coming on their colorectal rotation, let's say with us, and we do a lot of robotic rectal cancer surgery, for example. What does that look like in terms of having someone prepared, like a PGY2 or a PGY5? Yeah.
I could talk to you about that for a whole year. It's a wonderful question. This is the whole idea of basically, we asked that exact same question, Amir. We asked that exact same question because we asked that question. Why? Because we said, well, what does that mean to be prepared for a robotic rectal surgery? Well, how about if you're an intern? What does that mean to them? How about if you're second year? How about if you're a chief, right? So the way we've thought about it is that definition, actually, again, going back to that simple, complicated, complex problem. It's not a simple problem, right? And one solution, you cannot have one solution for a complex problem, which is exactly what you just asked. So how do you answer that question? First of all, you have to get the learning curve out of the way. So again, going back to the pragmatic level of actually preparing people for entrustment. So we basically now we're in the third or fourth year of basically having a complete rotation, month to 6 weeks of our interns spending in the lab. No clinical duties. Their job is simply to drill. They learn laparoscopy, robotics, endoscopy, fuse, energy, biosurgery. They just drill. And after a whole month of AI generated feedback and person-to-person generated feedback, they come out and guess what? They can dock that robot faster than me. They can get on the console faster than me. They can certainly use any, they know the in and out of every stapler, of every, they know that's their job, right? That makes me super comfortable to trust them already, just knowing that that's happened, right? Even open surgery, we have now an advanced open surgery curriculum that they go through. That's the first aspect. They come into the OR, then we say, okay, what does entrustment mean for a first year in a robotic rectal case? And this is where we divided it up to what we call nested EPAs, to basically say, we can't trust them to do a mesorectal excision. You wouldn't trust me to do a mesorectal excision, right? And so why would you trust an intern, right? And so the point being, at that point, we basically say we have these nested EPAs that are appropriate for entrustment for first and second years. These include putting in access, opening the abdomen, closing the abdomen, laparoscopic access, mobilizing of the hepatic flexure, mobilizing of the splenic flexure, mobilizing of the stomach, mobilizing of the sigmoid. That's the whole point. It's modules. It's not procedures, right? And it's a little funny because you'll hear a first year or second year say, "Oh, I'm interested in mobilizing a hepatic flexure." Well, I'm like, good luck finding somebody that comes into the hospital to get their hepatic flexure mobilized, right? But that's a good point. They at least have a part of the case that they own, and you can entrust them with them, and that not only builds up their ability for the fifth year entrustment, but also builds up that other two factors of trust. The benevolence and the factors of basically you knowing them, all of those things, and the integrity, and that all comes together so that you can trust them when they're seniors.
You talked about AI, and I know one of the big things you've done a ton of work on computer vision, all sorts of stuff. Where does AI fit into surgical education, surgical performance? Obviously, there's sort of the hype and the pipe dreams. As someone who actually is working on this actively and has published a ton in this space, where does AI fit into 2025 surgical education?
Yeah, it's a wonderful question. And I certainly don't take a lot of the credit for this. In fact, a lot of the people I've learned a lot from, Amir Madani, and he was in Montreal, now he's in Toronto, and obviously Julian Vares in Chile. A lot of people are working, in Pietro Mosconi in Italy, are working on amazing things to help us in surgical education and AI. And so to answer your question more directly, it depends on which domain we're looking at, right? If we're looking at the domain of simulation, it's unbelievably a game changer for us. And the reason why it's a game changer is because we're able to basically look at things that are one of the biggest issues with simulation is getting faculty and getting feedback for individuals so they can move along the simulation pathway. AI helps us with this, with computer vision. If we look at personalized education, the ability for people to drill and get feedback, whether it's clinical reasoning for medical students, or whether it's gathering knowledge or actually developing references, or whether it's a skill, again, AI is helping us do this at a low level fidelity. Now, the way we think about it is that we're basically using it for feedback up to a level. When people are transferring from a level to another, they need more expert feedback, but that decreases the burden on the faculty significantly. So that's a really important thing. I loved using AI for clinical reasoning for medical students up to a point again, right? So, and that helps them drill. So to answer your question, it's certainly not there to be a panacea. And I feel like one of the biggest things I've learned over time with AI, and even in the clinical world, and we've done a lot of work on using AI for basically determining, like Chad, you would love this. We just published a paper to basically say, can AI determine who will have a positive margin in a Whipple versus not? And actually showed that AI algorithms that are trained are actually better than expert pancreas surgeons and expert pancreas radiologists in predicting positive margin. So that's really helpful for me. So it's really exciting. But one thing I've learned really importantly about AI is that every time we try to do AI, whether it's computer vision or LLMs, as a package, say, okay, I want it to do blah, we fail or we fall short. When we say we want to develop an LLM or a computer vision to answer this specific question, it is incredible and it does its job. So if I say, I want you to assess this individual's technical skills in doing laparoscopic side-to-side hand sewn anastomosis, which we already have now, right? It does an incredible job. If I'm asking AI to actually look at it from a concept of indications or judgment, it fails miserably. So I think, does it have a place? Absolutely. Does it save us money? Does it save us time? Does it actually have the learner progress by giving them feedback? Absolutely. It's just the way that people are using it sometimes is wrong.
One really important thing that I just want to pick up on, and I think I partially asked this question at CSF. So we talk a lot about trust, and also you said that no learning happens without assessment, right? So historically, and I won't use the word that people used to use, but like the Socratic method of assessing where people are at, right? So can you name this structure, or list the 5 differential for bowel obstruction? What are your thoughts on that? Is that something that fits in with this model of trust? Is that something that's inherently doesn't follow with benevolence and integrity? Is that somehow aggressive? Because how do you figure out then where someone's at? Like, yes, okay, fine, you can have a programmatic thing that says this is what people should be doing, but sometimes people aren't there yet, right? How do you develop a sense of where people are at without actually, in some way, asking them?
I love how we're like all over the spectrum in surgical education. This is actually a fun conversation. I will tell you this. Remember, I said there are 5 things that a program is responsible for. One of them is faculty development, right? And I'm not a person that actually thinks faculty development is the answer for everything. In fact, I don't. I think actually a lot of times it's a cop-out. Sometimes the programs use that as a way to actually escape their responsibilities. But to answer your question, I love history. And so I want to kind of step back a little bit and actually say, even what we call the Socratic method is actually not the Socratic method, right? So Socrates actually used to ask questions for 3 reasons. He used to ask questions because he wanted to understand not what the learner knows, but how the learner has reached their conclusion, right? He also wanted to ask one question after another because he believed that he didn't know. He believed that he was like ignorant of like how to achieve virtue. And so he was trying to learn from his students, right? And he wanted to actually search for the truth, which is his third way. That is not what's happening when you're asking people, what are the 5 drugs that cause pancreatitis? That is not what's happening when you're asking people like, what is this structure? And this is the problem. So is there a place for dialogue, for you asking questions? Of course, that's actually incredibly important. However, it needs to be a dialogue and it needs to be pointed towards a higher cognitive thought than recall, right? Is there a place for asking for recall? If you're trying to break the ice and things like that, that's fine. But remember, in the end, adults and learners are adults, do not respond to embarrassment. If you embarrass an adult, all you've done is shut them down. And all you've done is shut down the entire learning environment. And so I always say to faculty, if the question you're asking could be answered by Siri or Alexa, then you're doing something wrong because it's not really going to be very helpful, right? So having a dialogue is important, but at the end, you want to step back and say, have I created an environment where this person is in a growth mindset that they actually don't mind being wrong? They don't mind embracing that discomfort. And that's an important part.
Adnan, thank you so much for spending the time with us. It's been an absolute pleasure. And we may have to get you on again for a part 2 when I come up with more questions after this.
Let's see how many thumbs down we get on this podcast first, and then we can discuss.
I don't care. Haters can go to hell. So one of the questions we always ask is, if you could go back in time, knowing what you know now to when you were a chief resident or maybe an early attending, what advice would you give yourself?
I love that question. And thanks for asking that. I still feel like the most important thing is understanding the importance of informal influence, understanding the importance of connecting with individuals. Often we are so hell-bent on learning a technique or learning something that we don't actually have a connection with individuals. And I feel like that connection is what actually builds trust, builds entrustment, builds autonomy, builds learning. And that goes a long way. Focusing on the humanity, the humility, the benevolence, the communication, I think that's something a lot of times we get so worked up in the whole, weeds of our practice that we actually forget that. And I feel that's an unfortunate thing that I learned way too late, but that's probably something I would change.
In some ways, what you're saying is, it's just like when people forget that there's like a patient in front of them, right? You're like, oh, this is not just someone with a colon cancer. Like this is a mom, dad, husband, brother, just like you would treat your own family member. And you're so right. We forget that sometimes with our trainees, like the people who are in many ways so vulnerable, right? Like they're spent so much time with us and really like at 2 a.m, you're standing across from someone doing something really tough, really, really traumatic sometimes.
There's a lot of talk about burnout and whatever. There's a wonderful book that's co-authored by Desmond Tutu and the Dalai Lama, and it's called The Book of Joy. And we literally are depriving ourselves from what gives us joy in our job. And it really hurts my soul when I ask somebody about joy and they talk about, the skiing or their dog or that. And trust me, I love all of that stuff. But if you don't have joy in what you're doing, 60% of your life, there's a problem, right? And I think that's the issue of focusing on these other things will give you joy in your work. And it's so tremendous to be able to go to work every day and feel like you never worked,
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.